Hello everybody, it's Martin Kiernan here and welcome to this episode of Infection Control Matters, and we're going to be looking at water safety in hospitals. And I'm delighted to say that the 2023 Nursing Times Award winners from Leeds hospitals are joining us. So we've got Dr. Jessica Martin, who's a consultant microbiologist, Adele, Dyche, who's a matron from Infection Prevention and Control, and Katie Sweeting, who's a matron in Haematology. Now, they came together to produce a multidisciplinary team looking at the problem of water safety. And it's very much an organisation that looks for multidisciplinary teams. So, Jessica, can I ask you to explain what the problem was first, what you identified, and then how you went about creating this MDT?
Thank you, Martin. So, thank you for inviting us to share some of the learning that we've had here in Leeds. So, as an infection prevention team, obviously we get called in when we see more than one case of the same organism in an area, and we put in the package of interventions that most IPC teams would do. And we had experience in adult haematology here where we had an outbreak related to Pseudomonas aeruginosa where we had done all of that and we hadn't solved the problem. And there were some really unusual features of that outbreak in the fact that the case numbers were very low. They were spread out over a very long period of time, over years, rather than what we would see in patient-to-patient transmission, which would be much more frequent instance. And we started to think that the wastewater systems may be relevant to the outbreak. So as you say, we do business in a very particular way in Leeds. It's called the Leeds Way. We get everybody around the table that may be of any relevance to help us solving a problem. And we've got all of our teams around, estates, facilities, obviously our clinical teams from the ward and the infection prevention team. And we started to think about wastewater and wastewater systems and what we might be able to do different. Mm-hmm. And we came up with a really two strands. The first thing was really looking at the built environment and modifying the built environment to make our patients safe from wastewater. And then the second strand is really quite an extensive clinical practice change to make sure that anybody that's going near wastewater systems is going to handle them with respect to make sure that any organisms down there do not get near our patients. And I think the final thing to really sort of introduce the topic is the fact that was one ward and one experience back in 2020. But what's been really remarkable and what Katie and Adele have done so robustly is get that learning, get it out of a single ward environment and interpret it in many ward environments across the hospital so that we are water safe in lots of different areas. So that's kind of been our experience.
Because the principles will be the same everywhere, won't it? It's just going to be more highlighted in certain specific areas. Can I ask you what the structural changes to start with then that you were able to make or you felt were necessary before we go on to behaviour, because that's often the hardest thing to change?
So the first thing that we did was we mapped the cases that we had in terms of where they were in the ward. We also mapped any positive water samples we had for any Pseudomonas, either part of the outbreak or not. And we also mapped on the kind of geographical map of the ward any plumbing issues that had been reported over the months of the outbreak in terms of blockages of sinks or toilets not functioning or anything, showers that were leaking, that kind of thing, so that we could understand the risk pattern across the ward. And I think it's really important that we also mapped the patient experience of water. So we looked at how did the patients get the water that they were going to drink? What was the process for those water jugs and for the cups, and how did we clean those? We looked at the process for water that was used for washing, both for bedbound patients and ambulant patients, and so on and so forth, so that we could start to build a map in our head, both of the process of patients and staff accessing the water, and of exactly where in the ward the risk might be. We've done that in an area not in haematology and found a very localised area where we think Pseudomonas may have been a problem from the wastewater, and we've dealt with the built environment just in that very localised area. In the case of the original outbreak, that didn't tell a story, that mapping, and actually what we think we had was a very low-level disseminated contamination that probably had occurred over many years. So we agreed as a multidisciplinary team to put interventions into the built environment to make it all safe, which was a large piece of work and involved all of the bathrooms being made water safe, the kitchens and other areas such as treatment rooms. And really the principles of the water safe building changes were really around making sure that nothing that was from down the drain could get near the patient. So for an example, for the showers, we made sure that when we refitted the showers, that the heads of the showers were fixed to the wall. There was no hoses, that there was a camber of the floor so that water would drain rapidly away. And it drained the drain away from where the patient was standing. So the shower head and the drain were at opposite ends of the shower area. So for every little bit of the water outlet, these built-in design features were very carefully discussed and planned to make sure that the patient was kept well away from the wastewater, and as were all those other bits of the pathway in terms of their water jugs, the water for washing food, etc. So that's how we address.
Now, it's interesting, isn't it? Because often when you stand under a shower, you're standing under the shower head, and the drain you're standing on top of the drain, so the water comes straight down you and straight over the drain. But you've moved that separately, so people actually aren't standing on the drain area. So I think that's straight off a nice bit of creative thought. Yeah, Katie, what did you do in your area then in haematology?
So I think the main thing initially, I remember right back at the beginning, walking the ward with Adele and just going, well, that probably shouldn't be in that room, and that probably shouldn't be in that room. And just sitting back and thinking about it all has made us realise, and we use that one ward now, that's kind of the model, that's the standard. We were very lucky because we were able, the actual template of the ward that we've got has lent itself for us to be able to do some very simple removal of a bath and turn that room into a storeroom, and then that enabled us to move some things out of the sluice that shouldn't be there and have real defined areas for everything.
Can I ask you to describe what the ward layout looks like? Because you're not a small organisation, are you? You are thousands of beds, if that's right. And you're a how many bedded ward, and what's the sort of layout you've got there?
So the layout, and I think it's really important to just explain that we are quite unique in the fact that we're lucky we're in a relatively new building. We've got a nurses station in the centre of the ward with 20 beds, 20 single side rooms, with all ensuite rooms, and then we've got a sluice and a kitchen and storerooms that are kind of, it's all in a bit of a horseshoe setting really. Mm-hmm. And I think what the important thing to note is that this model that we're using, we appreciate that not everybody has got the same template as us, and not everyone's got the same foundations to work with. So it's, what I think is the success of this is that we've been able to then adopt what we've used on the initial haematology ward and try and model it and allow it to be fit for purpose for every other area. Some of the estate in our trust is very, very old. I wouldn't like to guess how old some of the old buildings are and how long some of the pipework and structures have been in place, but it's allowed us to think, well, can we just move this and put that there to make it water safe, rather than having to knock down walls and do lots of industrial environmental work. So I think, we're lucky in the fact that we were able to quite quickly change our way of working, and it's had such a phenomenal impact on nursing staff feeling empowered to then be able to educate patients, to be able to educate new staff that are coming onto the unit. We are really confident that we know our processes, that nursing staff know the processes that the housekeepers should be using, and so forth. So it really does, it's quite interwoven in the fact that this package that we've made has made everybody much more aware of each other's business. And I now love sitting on Water Safety Group and listening to what states and facilities are doing. And I know that we have a bit of a laugh.
Almost no one ever.
Except me.
Katie, can I ask you how you became convinced that water was an issue in your organisation? Because I'm not sure that many nurses still get that actually a splash from a sink really could be an issue. What convinced you that actually this is something we need to do, apart from knowing there was a bit of an outbreak going on? Was there like a light bulb moment or something like that made you think, actually, this is something we've really got to run with here?
I just think undeniably, from seeing cases that we'd had and then speaking with Adele and Jessica, I realised that this was, and pardon the pun, but really like a bit of an unknown waters that we were going into. Yeah. It's something that nursing staff generally, when we've educated nursing staff about this, they've never put two and two together and realised that water can be harmful to patients. And actually, when you take a step back now, and I still probably enjoy is not the correct word, but I still get satisfaction in walking people around an environment and pointing out things that can be hazardous, and them going, crikey, actually, when you just step back, it's quite straightforward in the way that we can eliminate risk. And I just think the whole culture now, from nursing staff to patients, is phenomenal. We continue to do a monthly walk around just to make sure that all the changes that we put in place are sustained. And proudly, I can see that I can go into patients' rooms and say to them, hiya, just doing a monthly walk round. Can I ask you, were you educated about water when you were admitted to the hospital? And they say, yes, I know that I shouldn't put my toothbrush on the sink. I should keep it in my wash bag away from the sink. I shouldn't leave flannels to dry and then use them again in the bathroom. And the nursing staff are clearly on board. So I think we're doing something right in how passionate we are about spreading that message, because it's not something that we've waffled on about for a few months and then everyone's kind of forgotten about it. I think staff have realised it's actually effective. And
it's sustained, isn't it? Yeah. Adele, can I ask you, you did a walk around initially and said that shouldn't be there, that shouldn't be there. What sort of things were you picking up on right in the beginning?
So Katie's articulated amazingly well that water issues and water safety are not something that's embedded into nursing psyche, unless you're somebody that's doing an IPC job really and loves the environment. So things that we identified were toothbrushes around sinks, patients filling up cups from the sinks, flannels. Katie, do you want to tell them how you don't look at a flannel in a certain way anymore? It's a
flannels and sponges are just a no-go area.
But what we did notice is that there were a lot of clinical pieces of equipment that were located far too close to a sink. So they were in what we would call the splash zone. So we've worked very hard, as Katie's alluded to move things away from the direct splash zone, which is usually a metre around the sink. So for pulp products, they're no longer right next to the sluice macerator or right next to the conical sink that you might have in the sluice. Hand wash basins, we've worked very hard to keep them separate from, particularly in sluice environments, away from splashing, from disposal, from body fluids, etc. But it was also a hearts and minds piece, really, because, and as Katie said, embedding the knowledge that really isn't there in nursing teams at the moment, but in Leeds teaching hospitals, we have worked very hard to embed it across not just oncology, but in other areas. So specialist medicine environments, our adult critical care environments. It's taken a little while, but it's starting to bear fruit.
I mean, it's not going to change overnight, that's for sure, especially in an organisation the size of yours. So you talk to me about the education package then that you brought in for staff? How did you go about that? Was that face-to-face? Was that something on the hospital intranet? How did you go about educating the staff about this?
I'll let Katie come in here because I did the initial education with Katie and some of her team. However, the package was developed by Katie and her oncology colleagues.
Yeah, so initially Adele delivered some training to us, and then we've managed to adopt a PowerPoint presentation that we've been able to then share with the clinical educators, and then that was rolled out onto all the wards within oncology. We had a week where we had the PowerPoint presentation printed off and laminated and put on a board that was dragged around the wards, just to really highlight the kind of the launch of water safety. And then we've managed to, with that sort of information that we had, when other areas have wanted to adopt this outside of oncology, the foundations of the water safety package remain the same, but then people can add in additional things. So I'll say pediatrics, for example, they can add in the addition of sort of toys and things in bathrooms that wouldn't be an issue anywhere else, but you can make it unique for every area. And I think the beauty of it is that as a team here of us today that are on this podcast, we've been able to go across the trust and be evangelical about how we feel about it. And thankfully there's other members of staff that have been like us. So there's one of me now in crit care who loves it, in adequate critical care, and I have other members of staff that are like, are you the Pseudomonas matron? And I say, no, I'm just the matron for haematology. And then
that's
they
not
become
a name you want, really.
about it. although obviously we're very proud of what we've done, I think we are even more proud of the fact that it's got legs and it's been able to be adapted and rolled out throughout the trust. And we hope we can just keep going with this, because what we have done here, it feels very unique and very special, and we're very proud of it.
Jessica, can I ask you about the engagement from the other medical staff then? Could they see the changes happening around them, or were they actually actively engaged in that in these areas, and have they been engaged in other areas, do you think?
Yeah, so as Katie described, the principles of wastewater safety are very simple, aren't they? That there's a lot of evidence in the literature that CPE and other organisms are in the wastewater in a biofilm, and there's hundreds now of publications about outbreaks related to wastewater and the need to control that. I think the thing that we've been really lucky about in Leeds, like you say, is everybody from board to ward, including our clinical teams, have recognised, understood and believed that. And I think a lot of IPC is about belief, that people really recognise that is causing harm to patients. And our journey started with augmented care and vulnerable patients, but I think there's more evidence now that it's actually relevant across all wards, and that's certainly how we've adapted this here. So the clinicians have been really important. So obviously our haematologists were very close to the process of developing the educational package for the medics on the ward there. When we took the learning to adult critical care, it was a very different landscape, because we got into very complex conversations about patients that are static and ventilated compared to those that were kind of immunosuppressed and mobile. So the medics there were able to really bring their expertise into the design of water safe care within that environment. And I think what's really interesting there is that we've managed to develop some very novel answers to difficult problems. So we were very concerned about the way that we were caring for patients with lines, tracheostomies, etc. So we actually use warm, sterile water to wash some of those patients who are highly vulnerable. And it's very relevant to us because we're a trauma centre, there's a lot of wounds, and it just seems to make really good sense to know that as you are caring for those patients, you're using warm, clean water that is not going to contaminate them, that is water that's originated away from sinks and away from drains. So our medical staff have been brought in at all levels of the organisation and have been absolutely crucial in terms of making sure that all the interventions are safe and they can deliver safe care whilst we have those interventions, and also designing out water, in a way that makes their job safe as well, so that we're not sort of making things difficult in a critical care environment or a transplant environment. So they've been fantastic.
Now, making major changes like this never goes completely smoothly unless you manage to do something miraculous. So what do you think some of the barriers have been, or what have been some problems along the way that you've had to overcome? Could you give any good examples? Because people will come across that, we're not getting rid of water in our area, we're not changing our practice. How have you gone about addressing those issues?
So I think for everybody in infection control, hand hygiene is always a top priority, and it doesn't matter what country you work in, what healthcare environment you're working in, it's very important. And obviously part of that has been putting sinks at the front entrance of wards, in every bay, in every side room, and in many other areas. So our hospitals are not new in most of the UK, and they are full of many, many, many sinks, some of which are used and some of which are not used. And I think, if you were to start from scratch and build a hospital and you knew about the risks of wastewater and gram-negative resistance, Pseudomonas and CPE, you probably wouldn't put sinks in the locations that they are or in the number that they are. But the bottom line is that our hospitals are as they are, and none of us have a pocket of gold to solve these problems. So I think the biggest challenge really is, how do you do those adaptations to the built environment to reduce the risk in very busy hospitals where you don't have a huge budget to change that environment for the better, even when you've got that learning. So I think that's probably the biggest challenge.
Can I ask you who paid for the structural changes? Because in my experience, organisations tend to work in silos. And if you're going to need to do something that's a little bit broader, who's going to pay for that? And how did you make the case for the funding to actually even do anything structural to an organisation, which is, in many cases that organisations are running at full stretch and it's difficult to almost take beds out? Or did you have to, close areas to do some structural change, or will you actually manage to fit it in with normal flow?
So there's the proactive and the reactive, I think, is the answer to that question. So for the reactive changes, which is in the case where there's been transmission of infection from the wastewater system, there's been absolutely no barrier to finding the money to do that because it's the right thing to do. And every organisation I know would respond to those challenges in the right way if the right information is provided to those people that pay the bills. I think the proactive side of it is more difficult in the fact there is only a limited budget in the organisation to make areas water safe. And if you haven't actually got a problem, you've just got the learning, this is important work. You've got, patients with lines, for instance, in a renal gastroenterology ward. So it just makes sense that this is the right thing to do there. But you've got no problem to ever sit with, then that's when it's more difficult to find the money, I think.
Yeah, there's sometimes a problem when practice is so good that patients actually don't get infection because the line care is so good. That's sort of an issue, and then you're looking for any issues there. What's your experience of it, Adele? Have you felt about the whole process?
So there have been times, Martin, where national guidance hasn't helped us in terms of making the decisions about removal or changing an environment, because as you know, the HBN, infection control HBN 0009 is out of date, and it doesn't really cater for the current climate that we're in terms of wastewater. It doesn't factor that in. So you found yourselves at times in complete and utter being frozen, really, in terms of, do we follow what's written in front of us that we know is about 20 years out of date, or do we risk assess the environment, risk assess the care for our patients, and stick our heads above the parapet and do something that is going to make our patients at the end of the day safer than what the current guidance is. So that for us as a team, and I'm sure Jessica and Katie will agree, has been really, really difficult, because obviously you've got some schools have thought that you absolutely must follow the content to make yourselves compliant, yet we know that there is emerging strong evidence to suggest that wastewater is a big factor in transmission of particular water-liking organisms.
Yeah, I mean, the guidance that one sink per bed in an already cramped ITU
absolutely
is really going to be an issue, isn't it? And so did you go about doing risk assessments then and documenting risk assessments and saying, actually, we're going to diverge from national guidelines?
Absolutely. I'll let Jessica come in here because she's done rather a lot of work with our intensive care units, particularly around the one sink per bed guideline.
So for me, Martin, I think the HTM Pseudomonas addendum around is really important. It was from a really important learning from Belfast, and we all recognise the risk of Pseudomonas in augmented care. But there's still a strong flavour within that document of Legionella control. So at the very, very beginning of our story, we had a lot of conversations, particularly with our estates colleagues, about incoming water. And incoming water is largely anaerobic. It's very, very unusual to have a systemic pseudomonal problem. And certainly we weren't detecting Pseudomonas in our water samples, but we knew that we had it in our patients, and it was from the wastewater. So I think in terms of asking how we met challenges, I think it is about rethinking water safety in the water safety group of the organisation, and also within the kind of wider IPC culture, to say that water safety is not about the water coming out the tap and Legionella and temperature controls. It's about wastewater safety. And I think it's been really lovely that we didn't have to work very hard with our estates colleagues to get to that point here. But as I've been contacted by lots of organisations around the country, I'm not sure everybody in every water safety group is in that frame of mind at the moment. And I think part of that is potentially the way the national documents are written, to think a lot about incoming water and taps and less about drains and outflow.
Have you had any pushback from external regulators, or people coming in to inspect, or people who fund your organisation? Have they raised any concerns, or have they been quite happy with that approach? Because there's often governance structures to go through when you're going to diverge from or digress from guidance.
I mean, in short, we still meet the guidance and the term. Obviously, we absolutely still test incoming water and do all of the the things that everybody would do in response to a positive test. I mean, what we have seen is because of the water safety program we've run, we used to run in some of the units up to 7% water positivity. It's now much less than 1%. So it's quite a good surrogate marker of how water safe your cleaning practices are and your clinical practices, your nursing practices. So I think they're useful things to do, and we absolutely meet all of those requirements. So, yeah, no, we've not had any. I think most of what we're doing is above and beyond. I think the only thing that we've done really that derogates from national guidance is removing sinks from side rooms. I think that's been the real difference, and we've done that as an organisation in response to risk. But as I say, it is quite difficult to do that if there's no risk and you're not doing it as a response, if you want to do it proactively. There is now more published evidence, as I'm sure you've seen, Martin. There's a nice German paper showing reduction in HCI in critical care rooms that are sink free compared to critical care rooms with a sink. So I think now that the published evidence is coming through to follow up what we've done by local experience, I think we might have more leverage for a conversation about whether it is the right thing to have a sink in every bed space.
Yeah, Giovanni was on a podcast previously chatting about that, because that was just an incidental finding from a survey. Kate, can I ask you about interaction with your domestics, your environmental service workers, because they are key to making an area water safe as well. How did the education go with them? Who does that education, and how do your nurses interact with the hotel services staff when they're dealing with that aspect?
Yeah, they are absolutely key to this, and I think they are a workforce that are absolutely remarkable in the fact that if you give them a set of instructions and a set of guidelines and a way of doing something, they will absolutely stick to it to the T. And they've been doing that for many years. If they came into this trust and were told 20 years ago that this is the process that you use, and they've been doing that, then that's what they've stuck to. So I think we looked at cleaning practices within the 2 haematology wards and realised that actually some of the practices that we were doing, we could adapt and we should adapt, and therefore there was a period of retraining and using different techniques, using cloths, and it was very much led by the facilities supervisors. They were supportive. They've sat at the side of us with this every step of the way. They've been on board with it completely about re-education. But realising that also these staff work on the wards, and it's part for the ward staff to be able to recognise if they think something's probably not being done correctly or the new way that we've taught it. So I think once they got over the initial shock that we might be changing some of the initial practices, and we completely invested in letting them know why we were doing that, so they felt part of it, not that they were being done to, that we've got a problem here and you are absolutely vital in helping us to solve this.
That's
then they
key, isn't it?
They were a valued member of that team. Like toilet brushes, we had a whole hours and hours of meetings about toilet brushes and reusing toilet brushes and single-use toilet brushes, and then people worry about cost and plastic and the environment and all that kind of thing. But when we'd actually got them on board with that, you won't see a toilet brush hanging around on the haematology wards any longer. So
what did you decide to do? I'm on tenterhooks now. How did you resolve the toilet brush issue? What did you do with that?
Well, we've gone to single use. You use a toilet brush once, and you leave it around you. You use it once, and then you dispose of it.
Wow. Okay.
Which is not something we've ever done before.
No. I think many wouldn't do that. Jessica, you've got something to say here?
So I was just going back to so we started off talking about bathrooms and showers. We've always thought of showers as a risk for Pseudomonas dissemination and aerosolization. We've moved to hand wash basins. We've done a lot of work about the standard operating procedure for all staff using a hand wash basin, cleaning it, mending it, washing their hands in it. But actually, we've talked more recently about kitchens, and actually the facilities team here have reworked how they use the kitchen in terms of preparing food. And it's been a really beautiful piece of work where they've understood that actually there's a lot of clutter, too many cups, too many plates taken out and into kitchens that are never used. If you've got a ward where half the patients are asleep in the middle of the afternoon, they're not going to say yes to a cup of tea. They've redesigned some of the trolleys that they use, so they've got doors on so they can't get splashed and things like that. So lots of little tiny tweaks. It's actually been very money saving. They've actually saved loads of milk and things like that, as they've just really thought about their pathways of how they deliver food and drink to make them water safe. It's made them just really think with everything with a new life, with that liberation of redesigning how they work from the ground up. It's provided a lot of benefit on all sides, not just water safety. So it's been a really nice piece of work.
I mean, I think the kitchen is actually very important, because I remember seeing the film from Mike Weinbrand where people just get the water jug, take it in there to fill it up, and rather than hold it under the tap in the sink, they just put it on the base of the sink so the bottom of the jug gets covered in gram negatives from the sink strainer, and then you cart that back and stick it on the patient's locker. Adele, you wanted to come in there, I think.
Yeah, I was just going to say the facilities team have been invested in this from the get-go, really. They have wanted to be part of it. They've wanted to improve their practice. They've wanted to improve the journey that a patient has. And we couldn't have asked for more from them. Anything that we've asked of them, they've gone away, thought about it, and come back with a revised process, which in the end has been really, it's enhanced the patient journey. So, for example, I spent quite a few hours with them around cleaning a hand wash basin, and the way, just looking at the way that they were doing it, could we make it better? So instead of the 8-fold method with microfiber, we've now got 4 separate cloths to ensure that things from the drain don't get pulled up the tap and then onto the end of the tap end, which then obviously when they put the water on can be contaminating for staff hands. So it was just basically thinking in a different way, which they've relished the challenge really, and have been a key group of staff that have supported us from day one across all of the sites where we've had to look at the way that we're managing water and improving practice.
I often think actually facilities are a bit of a forgotten service, because if everything seems to run okay, then people tend to forget about them, and actually this is somewhere where they can actively engage in making things safer for patients, apart from you don't need to convince me that cleaning the hospital environment is not a really critical thing to do, but this is also a very important aspect of it as well. Have you noticed then, because you mentioned there's been blockages and that sort of thing going on, have you noticed the number of blockages of sinks has actually dropped? Because that must take up an awful lot of their time and money going around unblocking sinks, because people aren't dealing with that area correctly. Have you got any data you could actually have a look at and say, actually our blockages have dropped by 50%, therefore splash is going to go less, but you're saving a lot of time in that aspect as well?
Mm-hmm. We don't have data on the number of blocked sinks, but I think what we do have is a recognition that a blocked sink is a significant risk from a wastewater pathogen point of view. Absolutely. So we have a process by which a lot of our water safety training across the organisation has been about everybody being responsible for reporting a blocked sink, and it being an important thing to report, and that we have a way of identifying the sinks that have gone out of use because they're slow draining, so they don't have to be completely blocked, they can just be slow draining. They come out of use, remedial actions are taken by the estates team, and then the estates team leave a label on it so we know not to use that sink until it's cleaned, because obviously any remedial action may have liberated some bugs from the drain. So we've got quite a detailed process around block sinks that we feel is important. I think it's also important just to say that I think there's something about the wastewater pathogen thought process that draws you in. As Katie said, it's drawn in a number of matrons across the organisation here, and it's drawing in a number of colleagues from outside the organisation. I don't think Leeds is anywhere that has a specific problem compared to anywhere else. I think that we can see the problem. I think once you've seen it, you can't see a Pseudomonas on an ICU or a Stenotrophomonas or a Serratia anywhere in the organisation without thinking about the wastewater system that's near that patient. So I think it's important to reflect that I would hope that the difference in Leeds is the fact that we've recognised it and that we talk a lot about it, and not necessarily that our issues are any greater than anyone else's. We have a state from all ages, so we have buildings back to Victorian times and some that are very new. And I wouldn't say that the date of the building is relevant to this conversation. I think it's about what you can see and
what you do,
and not presuming that a Pseudomonas is a normal pathogen in either an ITU or a haematology patient. It's potentially not normal.
Have you got any evidence that it's actually working in having any impact on your gram-negative infections? It's probably quite early days from that point of view, 'cause especially as you said, you didn't have large numbers or anything like that. But is there any trends that you can pick up yet?
Yeah, it's interesting, isn't it? Because you start to have the conversation about, is this just the red flag that you only know that it's coming from the wastewater when it is a CPE? And actually, what does that mean for the other sensitive gram-negatives? So we do sensitivity testing on all our pseudomonads from water, and the vast majority are fully sensitive. So therefore, you only really see this as an acquisition route when there's a resistant organism. What I would say is we have had a reduction in pseudomonal bacteremias over the last 24 months. We have also had a reduction of gram-negative bacteremias. Like all IPC teams, we know that numbers ebb and flow, and we don't always know what we've done that's led to improvement. We have had that reduction in water outlet positivity, which I think is important in augmented care as a surrogate. And we have obviously closed, the outbreak. We haven't had a case in haematology since October 2021. So we know we've solved that problem for the time being. But these pathogens are in the pipes; they're there forever. Yeah. So the work has to be robust, it has to continue, and you have to get assurance that it's working, because we can't have a hospital with no pipes.
No, unfortunately not. I mean, you make a good point about you tend to get, we probably tend to get a bit exercised when it's a multi-resistant organism, but actually there's no reason why your biofilm in your drains isn't full of completely sensitive or fairly sensitive gram-negatives. It's not like a admission criteria. We're not letting you into the biofilm unless you're a CPE. You're just not coming in. You can go past straight down the drain. That's really not going to happen. That bounces on the biofilm door. I can't see that happening. So I think the future with sequencing would make quite a lot of a difference. Right, well, okay, thank you very much. I've been fascinated. Did you want to say something there, Katie? You're smiling.
Well, I just love bouncers on the biofilm door. It's just an absolutely awesome statement, and I feel as though we need to get it in somewhere.
Yeah, I think that we need to coin a phrase there, Katie. We need to work. Yeah. We need to try and get that worked in.
Okay, well, it just floated through my mind, and it's flouted out again quickly. What other communication methods have you actually used to get these messages out, Adele?
We've worked very closely with our estates colleagues and developed a water safety video, which is on round 2 at the moment. We'll happily share that when that's been edited and reviewed, because it's been out there now for about a year or so. And we've also done identifying what a block sink looks like. I know for some people that sounds barn. That sounds barn door obvious, but for some people when we delved, it wasn't. So we've developed a very, very short, snappy video about what a block sink looks like and what you do about it.
And are these videos publicly available? Can people get hold of them?
They're not at the moment, because they're going through a second review, because we've been utilising them for a little while now, so they need updating. There have been some requests for sharing the video, which we will do in due course.
Okay. Well, we'll keep our eyes peeled out for that one. Anyway, thank you very much for all of you. Dr. Jessica Martin, Adele Dyche, and Pseudomonas Matron Katie. I've thoroughly enjoyed chatting to all of you. Doubtless people are talking to you about this and call you up, and I suspect that's okay with you as well, isn't it, to try and get some experience from you? Absolutely. That's what we're here for. We're here to help, and we'd like people to be able to experience the journey that we've gone on. It's rocky at times, but we've made some real inroads, and we are starting to see a safer patient environment because we're managing our water and our wastewater appropriately. Very nicely said. Well, thank you very much to all of you. Really appreciate you spending the time to have a chat to me about this. And everybody out there, you know where Leeds is. It's in the north of England. Have a chat to them. Thanks, Martin.
Thank you.
Thanks very much for joining me, everybody.